What is coronary bypass graft surgery? Coronary artery bypass graft surgery (ACAB) is a procedure used to treat coronary artery disease. Coronary artery disease (ACAD) is the narrowing of the coronary arteries of the blood vessels that supply oxygen and nutrients to the heart muscle. ACAD is caused by a buildup of fatty material within the walls of the arteries. This buildup narrows the inside of the arteries, limiting the supply of oxygen-rich blood to the heart muscle. A cardio 20,140,127 V06. One way to treat the blocked or narrowed arteries is to bypass the blocked portion of the coronary artery with a piece of a healthy blood vessel from elsewhere in your body. Blood vessels, or grafts, used for the bypass procedure may be pieces of a vein from your leg or an artery in your chest. An artery from your wrist may also be used. Your doctor attaches one end of the graft above the blockage and the other end below the blockage. Blood bypasses the blockage by going through the new graft to reach the heart muscle. This is called coronary artery bypass surgery. Traditionally, to bypass the blocked coronary artery, your doctor makes a large incision in the chest and temporarily stops the heart. To open the chest, your doctor cuts the breastbone sternum in half lengthwise and spreads it apart. Once the heart is exposed, your doctor inserts tubes into the heart so that the blood can be pumped through the body by a heart-owned bypass machine. The bypass machine is necessary to pump blood while the heart is stopped. While the traditional open heart procedure is still commonly done and often preferred in many situations. Why might I need coronary artery bypass surgery? Your doctor uses coronary artery bypass graft surgery (ACAB) to treat a blockage or narrowing of one or more of the coronary arteries to restore the blood supply to your heart muscle. A cardio 20,140,400 to V01. Symptoms of coronary artery disease may include chest pain, fatigue, severe tiredness, palpitations, abnormal heart rhythms, shortness of breath, swelling in the hands and feet, indigestion. Unfortunately, you may not have any symptoms in early coronary artery disease, yet the disease will continue to progress until there's enough artery blockage to cause symptoms and problems. If the blood supply to your heart muscle continues to decrease as a result of increasing blockage of a coronary artery, you may have a heart attack. If the blood flow can't be restored to the particular area of the heart muscle affected, the tissue dies. There may be other reasons for your doctor to recommend CAB surgery. What are the risks of coronary artery bypass surgery? Possible risks of coronary artery bypass graft surgery (ACAB) include bleeding during or after the surgery, blood clots that can cause heart attack, stroke, or lung problems, infection at the incision site, pneumonia, breathing problems, pancreatitis, kidney failure, abnormal heart rhythms, failure of the graft, death. There may be other risks depending on your specific medical condition. Be sure to discuss any concerns with your doctor before the procedure. What happens during coronary artery bypass? Coronary artery bypass graft surgery (ACAB) requires a stay in a hospital. Procedure may vary depending on your condition and your doctor's practices. Generally, CAB follows this process. You will be asked to remove any jewelry or other objects that may interfere with the procedure. You will change into a hospital gown and empty your bladder. You will lie on your back on an operating table. The anesthesiologist will continuously monitor your heart rate, blood pressure, breathing, and blood oxygen level during the surgery. Once you are sedated to put into a deep sleep, a breathing tube will be put into your throat and you will be connected to a ventilator, which will breathe for you during the surgery. A healthcare professional will insert an intravenous line in your arm or hand. Other catheters will be put in your neck and wrist to monitor your heart and blood pressure, as well as to take blood samples. A catheter will be put into your bladder to drain urine. The skin over the surgical site will be cleaned with an antiseptic solution. Once all the tubes and monitors are in place, your doctor will make incisions or cuts on one or both of your legs or one of your wrists to access the blood vessels to be used for the grafts. He or she will remove the vessels and close those incisions. The doctor will make an incision and cut it below the Adam's apple to just above the navel. The doctor will cut the sternum or breastbone in half lengthwise. He or she will separate the halves of the breastbone and spread them apart to expose your heart. Coronary artery bypass graft surgery (on-pump procedure). To sew the grafts onto the very small coronary arteries, your doctor will need to stop your heart temporarily. Tubes will be put into the heart so that your blood can be pumped through your body by a heart-lung bypass machine. Once the blood has been diverted into the bypass machine for pumping, your doctor will stop the heart by injecting it with a cold solution. When the heart has been stopped, the doctor will do the bypass graft procedure by sewing one end of a section of vein over a tiny opening made in the aorta and the other end over a tiny opening made in the coronary artery just below the blockage. If your doctor uses the internal mammary artery inside your chest as a bypass graft, the lower end of the artery will be cut from inside the chest and sewn over an opening made in the coronary artery below the blockage. You may need more than one bypass graft done, depending on how many blockages you have and where they are located. After all the grafts have been completed, the doctor will closely check them as blood runs through them to make sure they are working. Once the bypass grafts have been checked, the doctor will let the blood circulating through the bypass machine back into your heart, and he or she will remove the tubes to the machine. Your heart may restart on its own, or a mild electric shock may be used to restart it. Your doctor may put temporary wires for pacing into your heart. These wires can be attached to a pacemaker, and your heart can be paced, if needed, during the initial recovery period. Coronary artery bypass surgery off-pump procedure. Once your doctor has opened the chest, he or she will stabilize the area around the artery to be bypassed with a special instrument. The rest of the heart will continue to function and pump blood through the body. The heart-lung bypass machine and the person who runs it may be kept on standby just in case the procedure need to be completed on bypass. The doctor will do the bypass graft procedure by sewing one end of a section of vein over a tiny opening made in the aorta, and the other end over a tiny opening made in the coronary artery just below the blockage. You may have more than one bypass graft done, depending on how many blockages you have and where they are located. Before the chest is closed, the doctor will closely examine the grafts to make sure they are working. Procedure completion, both methods. Your doctor will sew the sternum together with small wires like those sometimes used to repair a broken bone. He or she will insert tubes into your chest to drain blood and other fluids from around the heart. Your doctor will sew the skin over the sternum back together. Your doctor will put a tube through your mouth or nose into your stomach to drain stomach fluids. He or she will then apply a sterile bandage or dressing. What happens after coronary artery bypass surgery? In the hospital, after the surgery, you will be taken to the intensive care unit to be closely monitored. Machines will constantly display your electrocardiogram, leg tracing, blood pressure, other pressure readings, breathing rate, and your oxygen level. Coronary artery bypass surgery at CABR requires an in-hospital stay of at least several days. You will most likely have a tube in your throat to help with breathing through a ventilator or breathing machine on until you are stable enough to breathe on your own. As you continue to wake up from the anesthesia and start to breathe on your own, your doctor can adjust the breathing machine to allow you to take over more of the breathing. When you are awake enough to breathe completely on your own and you are able to cough, your doctor will remove the breathing tube. After the breathing tube is out, a nurse will help you cough and take deep breaths every couple of hours. This will be uncomfortable due to soreness, but it is very important that you do this to keep mucus from collecting in your lungs and possibly causing pneumonia. Your nurse will show you how to hug a pillow tightly against your chest while coughing to help ease the discomfort. The surgical incision may be tender or sore for several days after a CAB procedure. Take a pain reliever for soreness as recommended by your doctor. Aspirin or certain other pain medicines may increase the chance of bleeding. Be sure to take only recommended medicines. Your doctor may deliver medicines through them to help your blood pressure and your heart and to control any problems with bleeding. As your condition stabilizes, he or she will gradually decrease and then stop these medicines. Once your doctor removes the breathing and stomach tubes and you are stable, you may start to drink liquids. You can gradually include more solid foods as you can handle them. When your doctor determines that you are ready, you will be moved from the EQ to a post-surgical nursing unit. Your recovery will continue there. You can gradually increase your activity as you get out of bed and walk around for longer periods. You can eat solid foods as soon as you can tolerate them. A member of your care team will arrange for you to go home and schedule a follow-up visit with your doctor. At home, once you are home, it will be important to keep the surgical area clean and dry. Your doctor will give you specific bathing instructions. Your doctor will remove the sutures or surgical staples during a follow-up office visit if they were not removed before leaving the hospital. Do not drive until your doctor tells you it's okay. You may have other activity restrictions. Tell your doctor if you have any of the following: fever of 100.4 to 38 or higher, or chills, redness, swelling, or bleeding or other drainage from any of the incision sites. Increase in pain around any of the incision sites. Trouble breathing, rapid or irregular pulse, swelling in the legs, numbness in the arms and legs, persistent nausea or vomiting. Your doctor may give you other instructions after the procedure, depending on your situation. Next steps. Before you agree to the test or the procedure, make sure you know the name of the test or procedure, the reason you are having the test or procedure, what results to expect and what they mean, the risks and benefits of the test or procedure, what the possible side effects or complications are, when and where you are to have the test or procedure, who will do the test or procedure, and what that person's qualifications are, what would happen if you did not have the test or procedure, any alternative tests or procedures to think about, when and how will you get the results, who to call after the test or procedure if you have questions or problems, how much will you have to pay for the test or procedure. Cardiovascular disease (VISTA) is a general term for conditions affecting the heart or blood vessels. It's usually associated with a buildup of fatty deposits inside the arteries, atherosclerosis, and an increased risk of blood clots. It can also be associated with damage to arteries in organs such as the brain, heart, kidneys, and eyes. VISTA is one of the main causes of death and disability in the UK, but it can often largely be prevented by leading a healthy lifestyle. There are many different types of VISTA. Four of the main types are described on this page. Coronary heart disease. Coronary heart disease occurs when the flow of oxygen-rich blood to the heart muscle is blocked or reduced. This puts an increased strain on the heart and can lead to angina, chest pain caused by restricted blood flow to the heart muscle. Heart attacks are where the blood flow to the heart muscle is suddenly blocked. Heart failure, where the heart is unable to pump blood around the body properly. Read more about coronary heart disease. Strokes and TIAs. A stroke is where the blood supply to part of the brain is cut off, which can cause brain damage and possibly death. A transient ischemic attack, also called a TIA or mini stroke, is similar, but the blood flow to the brain is only temporarily disrupted. The main symptoms of a stroke or T can be remembered with the word FAST, which stands for face of the face may have drooped on one side, the person may be unable to smile, or their mouth or eye may have dropped. Arms of the person may not be able to lift both arms and keep them there because of arm weakness or numbness in one arm. Speech, or their speech may be slurred or garbled. They may not be able to talk at all, or they may not be able to understand what you are saying to them. Time is time to dial 999 immediately if you see any of these signs or symptoms. Peripheral arterial disease of PAD. Contents. Overview. Diagnosis. Treatment. Peripheral arterial disease of PAD is a common condition where a buildup of fatty deposits in the arteries restricts blood supply to lead muscles. It's also known as peripheral vascular disease of PAD. Symptoms of peripheral arterial disease. Many people with PAD have no symptoms. However, some develop a painful ache in their legs when they walk, which usually disappears after a few minutes of rest. The medical term for this is intermittent claudication. The pain can range from mild to severe, and usually goes away after a few minutes when you rest your legs. Both legs are often affected at the same time, although the pain may be worse in one leg. Other symptoms of PAD can include hair loss on your legs and feet, numbness or weakness in the legs, brittle, slow-growing toenails, ulcers, open sores on your feet and legs, which do not heal, changing skin color on your legs, such as turning paler than usual or blue. This may be harder to see on brown and black skin. Shiny skin. In men, erectile dysfunction. The muscles in your legs shrinking, wasting. The symptoms of PAD often develop slowly over time. If your symptoms develop quickly or get suddenly worse, it could be a sign of a serious problem requiring immediate treatment. When to see ECPS. You should see ECPS if you experience recurrent leg pain when exercising. Many people mistakenly think this is just part of growing older, but there's no reason why an otherwise healthy person should experience leg pain. PAD is usually diagnosed through a physical examination by ECPS, and by comparing the blood pressure in your arm and your ankle. A difference between the two may indicate pad and is called the ankle brachial pressure index APIA. Causes of peripheral arterial disease. PAD is a form of cardiovascular disease of vista because it affects the blood vessels. It's usually caused by a buildup of fatty deposits in the walls of the leg arteries. The fatty deposits atheroma are made up of cholesterol and other waste substances. The buildup of fatty deposits on the walls of the arteries makes the arteries narrower and restricts blood flow to the legs. This process is called atherosclerosis. There are certain things that can increase your chances of developing PAD and other forms of VIST, including smoking, the most significant risk factor, type 1 diabetes and type 2 diabetes, high blood pressure or hypertension, high cholesterol, growing older, treating peripheral arterial disease. PAD is largely treated through lifestyle changes and medication. Exercising regularly and not smoking are the main lifestyle changes that can ease the symptoms of PAD and reduce the chances of it getting worse. It's also important to eat a healthy diet, lose weight if you're overweight or obese, moderate your consumption of alcohol, read about stopping smoking, exercise. The underlying causes should also be treated, including high blood pressure, high cholesterol, and diabetes. Medicine and, in some cases, surgery can be used to improve the blood flow in your legs. With treatment, most people's symptoms remain stable and some people may experience an improvement in their pain. If treatment is unsuccessful, there's a risk of potentially serious complications. Complications of peripheral arterial disease. PAD is not immediately life-threatening, but the process of atherosclerosis that causes it can lead to serious and potentially fatal problems. Coronary heart disease (CHH). The blockages in the arteries in the legs can also affect other areas of your body, such as the arteries supplying the heart and brain. This means that having PAD makes you more likely to develop another form of cardiovascular disease of vista, such as coronary heart disease, stroke, heart attack, angina, critical limb ischemia coli. If the blood flow to the legs becomes severely restricted, critical limb ischemia coli can develop. CLI is an extremely serious complication that can be challenging to treat. Symptoms of CLI include a severe burning pain in your legs and feet that continues even when you're resting, your skin turning pale, shiny, smooth, and dry, wounds and ulcers, open sores on your feet and legs that do not heal, loss of muscle mass in your legs, the skin on your toes or lower limbs becoming cold and numb, turning red and then black, and or beginning to swell and produce smelly pus, causing severe pain. Gangrene. Changes in skin color may be harder to see on brown and black skin. If you think you're developing symptoms of CLI, contact EGPS immediately. If this is not possible, call 111 or use 111 online. An angioplasty or bypass graft is usually recommended if you have CLI, although these may not always be successful or possible. In a few cases, an amputation below the knee may be required. Aortic disease. Aortic diseases are a group of conditions affecting the aorta. This is the largest blood vessel in the body, which carries blood from the heart to the rest of the body. One of most common aortic diseases is an aortic aneurysm, where the aorta becomes weakened and bulges outwards. This doesn't usually have any symptoms, but there's a chance it could burst and cause life-threatening bleeding. Read more about aortic aneurysm. The exact cause of VIST isn't clear, but there are lots of things that can increase your risk of getting it. These are called risk factors. The more risk factors you have, the greater your chances of developing VIST. If you're over 40, you will be invited by your IPS for a knees health check every 5 years. Part of this check involves assessing your individual VIST risk and advising you how to reduce it if necessary. High blood pressure. High blood pressure or hypertension is one of the most important risk factors for VIST. If your blood pressure is too high, it can damage your blood vessels. Read more about high blood pressure. Smoking. Smoking and other tobacco use is also a significant risk factor for VIST. The harmful substances in tobacco can damage and narrow your blood vessels. High cholesterol. Cholesterol is a fatty substance found in the blood. If you have high cholesterol, it can cause your blood vessels to narrow and increase your risk of developing a blood clot. Read more about high cholesterol. Diabetes. Diabetes is a lifelong condition that causes your blood sugar level to become too high. High blood sugar levels can damage the blood vessels, making them more likely to become narrowed. Many people with type 2 diabetes are also overweight or obese, which is also a risk factor for VIST. Inactivity. If you don't exercise regularly, it's more likely that you'll have high blood pressure, high cholesterol levels, and be overweight. All of these are risk factors for VIST. Exercising regularly will help keep your heart healthy. When combined with a healthy diet, exercise can also help you maintain a healthy weight. Being overweight or obese. Being overweight or obese increases your risk of developing diabetes and high blood pressure, both of which are risk factors for VIST. You're at an increased risk of VIST if your body mass index of BMI is 25 or above. Use the BMI Healthy Weight Calculator to work out your BMI. You're a man with a waist measurement of 94 about 37 inches or more, or a woman with a waist measurement of 8 about 31.5 inches or more. Family history of VIST. If you have a family history of VIST, your risk of developing it is also increased. You're considered to have a family history of VIST if either your father or brother were diagnosed with VIST before they were 55, your mother or sister were diagnosed with VIST before they were 65. Tell your doctor or nurse if you have a family history of VIST. They may suggest checking your blood pressure and cholesterol level. Ethnic background. In the UK, people of South Asian and Black African or African Caribbean background have an increased risk of getting VIST. This is because people from these backgrounds are more likely to have other risk factors for VIST, such as high blood pressure or type 2 diabetes. Other risk factors. Other factors that affect your risk of developing VIST include: age of VIST is most common in people over 50, and your risk of developing it increases as you get older. Gender. Men are more likely to develop VIST at an earlier age than women. Diet. An unhealthy diet can lead to high cholesterol and high blood pressure. Alcohol. Excessive alcohol consumption can also increase your cholesterol and blood pressure levels and contribute to weight gain. Continuing education activity. While leukemias are the most common type of malignancy affecting the pediatric population, brain tumors are the most common solid tumors in this population. Medullostosis is the most common malignant brain tumor in children, constituting nearly 20% of all pediatric brain tumors. It is categorized as an embryonal neuroepithelial tumor of the cerebellum. Surgical resection followed by radiation and chemotherapy are the mainstay of therapy, with 5-year survival rates ranging between 20 and 100%. This wide range is multifactorial and in part to age at diagnosis. Presence of metastasis. Objectives. Describe the epidemiology of medullostosis. Explain when the diagnosis of medullostosis should be considered. Identify treatment considerations for patients with medullostosis. Describe how enhanced coordination of the interprofessional team can lead to more rapid recognition of medullostosis and subsequently improve their evaluation, enhancing detection of pathology and allowing for treatment when indicated. Introduction. While leukemias are the most common type of malignancy to afflict the pediatric population, brain tumors are the most common solid tumors in this age group. One medullostosis is the most common malignant brain tumor in children, constituting nearly 20 of all pediatric brain tumors. It is categorized as an embryonal neuroepithelial tumor of the cerebellum. This is a high-grade tumor that has a propensity to spread via the cerebrospinous fluid. Within the first few years of diagnosis, mortality approximates 15. However, cure rates can reach as high as 60 with current therapeutic modalities. 3 for surgical resection preceded and or followed by radiation and chemotherapy is the mainstay of therapy, with 5-year survival rates of between 50 to 90. This wide range is multifactorial and in part to age at diagnosis, the presence of metastases at diagnosis, and a histologic variant of medullostosis 1-5 regardless of long-term survival. Treatment-related cognitive, neurologic, and endocrinologic effects remain a debilitating concern. Go to etiology. There is no clear etiology to medullostosis. Some studies have found a link between maternal diet and blood immune disorders during pregnancy. 6 others report an association with viral infections. For example, early John Cunningham GH viral infections or human cytomegalovirus cameo infections in childhood. 7-8 medullagulus may have a familial association and are also known to be associated with Gorlin syndrome, Fanconi anemia, Turcot syndrome, Li-Ferretti syndrome. Epidemiology. Examining data from the surveillance, epidemiology, and end results. A SIRA database from 1973 through 2007. The annual incidence for medullostomas was reported at 6 per million children. In other words, approximately 450 new pediatric cases per year. Children aged 4 to 9 years old had the highest incidence at 44, followed by adolescents at 10 to 16 years old at 23, and only 12 incidents in infants toddlers 0 to 3 years old. Pediatric incidence was calculated to be tenfold higher than adult incidence. Medullostomas go to pathophysiologically duct originate from the granule cell precursors in the external germinal layer medulla of the developing cerebellum. Tumor growth starts in the fourth ventricle and then can grow to occupy it completely. After that, the tumor spreads to the cerebellar vermis and the brainstem, seeding the craniosopinal axis. Medullostomas is a highly malignant tumor with a propensity for local invasion and distant metastatic spread through the subarachnoid system within the brain and along the spinal cord, also known as drop metsa 11. Extraneral metastases in pediatric medulloplasias are an infrequent occurrence, approximately 7. The most frequent sites of extraneral metastasis in children include bone of 78, lymph nodes of 33, liver of 15, and lungs of 11. The average time to develop after maximal surgical resection is approximately 20 months. Survival in these cases is dismal and in most cases can be less than 6 months 12. Notably, the most common cytogenetic mutation encountered in medullostomas is ischosarmyso 17, resulting from the loss of the short arm apia with a resultant gain of genetic material from the long arm acua. Also, deletions in the short arm have also been frequently reported, leading to loss of heterozygotes of 17, like 7, 10 to 13, 14, 15. Interestingly, the tumor suppressor gene, 53, which is located on chromosome 17, is rarely mutated in medullostomas 16, 17. Thus, the search for putative tumor suppressor genes on chromosome 17 in the go-to histopathola. The 5 histologic subtypes encountered in medullostomas include classic desmoplastic nodular ADN, large cell anaplastic Welchia, melanotic medullosumable. In classic medullostomas, sheets of small round cells possessing a high nuclear to cytoplasmic ratio are noted. They have a high invasive tendency and possess occasional neuroblicus differentiation. The classic type constitutes approximately 70 of medulloplasias. Nodules of tumor cells displaying neurocytic differentiation on a collagen-rich matrix characterize the desmoplastic variant of these tumors are less aggressive than the classic variant and account for 15 of medulloplasias. Large cell anaplastic medulloplasias, as the designation suggests, demonstrate features of anaplasia. These features are large. History and physical. Given its origin in the cerebellum with the propensity of locally spreading into the fourth ventricle, patients most often present with a combination of cerebellar signs like clumsiness, gait disturbances, and obstructive hydrocephalus, for example, early morning headaches, nausea, vomiting, double vision, or blurry vision. Since the majority of medulloplasias are in the fourth ventricle, obstructive hydrocephalus is not uncommon. These patients may present with emesis, headache, and lethargy. Time from symptom onset to diagnosis is usually short, usually 2 to 3 months 11-20. Almost all patients have early signs of elevated intracranial pressure that is associated with headache early in the morning and relieved over the course of the day. Patients with Cushing triad usually have impending herniation and need immediate treatment. The tumor in the cerebellum can also lead to ataxia and truncal unsteadiness. If the brain stem is involved, it may lead to cranial nerve palsies that may present as diplopia, hearing loss, facial weakness, and head tilt. Fundoscopy may show optic pallor or papilledema. Paralysis of the abducens nerve may lead to an inability to abduct the eye. Sign may be seen in some infants. Measurement of the head circumference in infants may reveal macrocele. Go-to evaluation. Investigations should include routine laboratories, including thyroid function tests. Computed tomography corda of the brain may reveal mass in the fourth ventricle. Most medulloplasias are contrast-enhancing. Hydrocephalus is common in most patients. Magnetic resonance imaging MRI is performed in all patients as it demonstrates the anatomy better than CT scan. MRI is often used to detect post-surgical residual disease. Spinal MRI is also useful for detecting metastatic spinal lesions. Other tests include audiometry prior to starting cisplatin treatment. Echocardiogramic and pulmonary function tests are obtained as a baseline prior to the start of chemotherapy. A lumbar puncture may reveal leptomeningeal tumor spread. But despite a positive MRI, Cerebrospinous fluid occlusion may be normal. Prior to lumbar puncture, fundoscopy is done. Following surgery, lumbar puncture is delayed for at least 2 weeks because the surgery may have caused tumor dissemination, leading to a false positive result.